This is Dying Your Way.
Welcome everyone to the Dying Your Way podcast. I'm Claire O'Berry. I'm your host. The most beautiful woman will be our guest today, and someone who's taught me everything I know about being an end-of-life doula. My mentor and trainer for end-of-life care is Deanna Cochran. And before I introduce you to Deanna, I just want to give her a shout out because she is you'll see the kind heart, but she's a registered nurse, hospice nurse, so expert in palliative care, and she's a best-selling author, and she is really in the United States a pioneer in the end of life doula movement, which we will be talking about more through the podcast. I've interviewed Deanna before for my podcast like 5 years ago, and we've already covered like what is an end of life doula, and we can get into that a little bit, but I would really recommend you go back and listen to the earlier podcast with Deanna because that's still very, very relevant. But right now we're going into a very challenging time for end of life care, not just in the United States, but globally. And there are some reorganizations that are happening at a government level in the United States that frankly caused me great concern. I looked at the statistics of where the Australia falls in end of life care and where the United States falls in end of life care. And this is personal. It's just like because I'm looking at my death and my end of life journey like everybody else. And Australia ranks fourth in the world, and the United States ranks 47th in the world, looking at 81 countries, 85, 87 countries, things like that. So, that's, they're like sandwiched between Myanmar and Colombia. That's where the United States falls. And I used to tell my friends in Australia, I'd say, I want medical care here in Australia, universal health care. But I want end of life in the United States because at that time, with the support of hospice and palliative care, and that they knew about end of life doulas and everything, that was where I wanted to die. I can't say that anymore. So we're going to explore what that is with just one of the best people I know to talk about any kind of quality of life at the end of life. And that's my friend and mentor, Deanna Cochran. So here I will reintroduce you to Deanna. Hey, Deanna, look at you. I'm so happy you're here. Thank you.
No, just really looking forward to our discussion about how really, all the things you say are true, how doulas can step up, really.
Yeah.
Let's point out and we'll explore some things around how doulas can step up
Well, I think
because
I didn't want to be a negative Nelly there at the beginning, but it's
God, it's real.
it's really turned a corner in the last few years and months. No, is there anything that you want to add to that introduction or some sort of foundation that you want to lay to this audience about the role of an end of life doula?
Well, for the people who don't know what an end of life doula is, like maybe they just stumbled on your podcast,
Yeah.
bottom line, we're non-medical. It's a non-medical role that provides practical emotional support, pretty much. The default definition would be an advocate, say, companion. And now, given that, know that so many different people from different backgrounds, healthcare professionals, non-medical professionals are getting into it. So depending on what an individual's background is what they're going to specialize in their practice. But what we all have in common, should have in common, is an end of life expertise and a desire to make the dying time better. And how you do that will be dependent on who you are, what your talents are, what your skill set is, what you would like to do. That's what I teach.
Well,
What,
let's go back even further then, because what would be the metrics of a good death, in your opinion?
oh wow, that's a big one. Really, the possibility to me, a good death would be one where the person who's dying isn't physically suffering. To me, that's it right there. The sadness of it all, the grief of it all, the existential grief, all the pain of that emotional pain, all of the spiritual pain, anything that's going on like that
Mhm.
is going to happen. It is what it is. When people are dying, that's what people usually face. That part, to me, you can do that and handle that and be able to come to peace, possibly, if there is, if you're physically cared for.
Mhm.
So if the person who's dying is not physically maintained well, then the family is full of anxiety as well as the person being in pain. They also have a lot of anxiety about it. Of course, they're trying to cope and manage, and they're super coping, and they're trying, and all that energy. And then the family is really going through it because they know they're suffering. So to me, is if the person who's dying is managed well with good symptom management, physical symptom management, then whatever else needs to be worked out has the potential to be. Not saying that it will be or that it'll be a beautiful death or anything like that. But to me, that's the bottom line.
Of all the different kinds of families that you've worked with, do you get an opportunity to train them to be a better support? How closely do you work with the families as opposed to the patient themselves?
Oh, I always work with the families. It's mostly working with the families. For me, when I've done private work, I'm usually, my private practice is preparing the family most often. The person who's dying, by the time a family comes to me in my private practice, often they're not responsive in a way that they normally are. The family's already, the medical power of attorney has already taken over and things like that. Because people up to recently mostly are not preparing ahead of time. It's starting to change. It really is. People are talking more and there's more conversations and I have done my share of pre-death planning with healthy people, but for the most part, people come to me at the end
Yeah,
in a tailspin because they're in a crisis.
yeah, yeah. And I remember learning from you that people don't take the hospice benefit soon enough for the most part to get the benefit out of hospice. So that would be the same would hold true for an end of life doula. It's like, yeah, we know what to do when it's wherever they are. We meet them wherever they are. But if they brought in an end of life doula to develop an end of life plan, once they got a diagnosis, even they may not die from that, but even if we're all going to die, and just to get that plan in place as early as possible. I mean, do you get an opportunity to work with clients like that?
I have a few times, just a few times.
Hmm.
With me, I the work that I do and I've known for and the referral system that developed around my early work in 2005 lends itself to people calling me in crisis.
Hmm.
That's what I like to do. I'm an end of life doula who's also has 15 years hospice behind me, nursing. And so and there are a lot of doulas that are hospice nurses. There's a lot of doulas that are non-medical. They're never been in the medical system at all. So there's a place for each one of us
Hmm.
to accompany the dying and to help make dying better, to make that time from when treatments begin to stop working to hospice entry, into services, to make that time be not as up and down and all these exacerbations and in and out of the hospital and poor symptom management. If there's somebody in the picture that understands how decline happens,
Yeah.
this is the dying, right? It's the dying time, even though true dying is happening, say the imminent dying time of a couple of weeks to death is happening at the very end of life. Most of the dying is happening prior
Yeah.
and not on hospice because physicians don't refer soon enough. That's been the trouble hospice has been dealing with for since it began, is that that physicians don't refer soon enough.
See, and when mother and daddy were under hospice care, that was before Medicaid um, changed their rules, and mother had Alzheimer's, was under hospice care for 6 years. She was
Right.
evaluated every 6 months, but she was continually, failure to thrive was her diagnosis. And then daddy was under hospice care in and out because he would get better and he'd go off for 2.5 years. But we already had the nurse, we already had the case number, and so their experience of dying in the United States at home with me as their main caregiver was just like perfect because it was like I had that support of hospice. And it was like I didn't have to hold all of that. They held it. And all I had to do was love mother and daddy and be a chauffeur and be sure they took their meds.
Huh, yeah, that would be nice if that would happen for most people. But I think it's something like 50% of people are come into hospice, the latest stats in the Facts and Figures report they do every 2 years.
Mhm.
It's about 50% come in the last 2 weeks, last 2 to 3 weeks. So that means 50% of people are coming in then from 2, 3 weeks to years, right? So you've got 3 weeks, 4 weeks, 5 weeks. See, like there's they have it month by month. It's pretty it's interesting that that should be so when, you know, all this the suffering, all the books that the physicians, all the prominent physicians are writing about this time period and the excellence of palliative care to deal with people's end of lifetime, and everybody's so concerned about money and expenditures, and
Rod.
you would be further along, but here we are. So now we have this whole layer of professionals, right? Not every end of life doula wants to work professionally in the community, but if they do, um, I'm going to look at you and I need to, um, if you do, then you need to know what you're doing. So take it upon yourself to get trained well. Some of you already know what to do. Some of you are just born like you're that person in the family, you know what to do. Then get out there if that's what you want. We need you. Just come on. You're comfortable with business, you're comfortable starting your own business, you're comfortable with being with the dying, you're comfortable advocating, then just come on. You don't need a certification. Nowhere in the world do I know that you have to have a certification to hang up your shingle as an end-of-life doula, but it's my opinion that you do need to know what you're doing.
Oh God, yeah. And a standard of care.
Just have a standard of care, but the main thing is around the advocacy of helping them, having their back, whoever you're with, having their back. Like you were saying, you could just be there and help your family, love them, take care of their needs. You weren't swimming with all these.
I didn't need to be a clinician. I had
Yeah,
hospice there to do it.
yeah.
One of the things that's really just in the last couple of years that's happened here in Western Australia, which, I mean, I was one of the vocal people, but certainly not the only one. They have something called Western palliative care. And because Western Australia is like you could fit Texas inside Western Australia. It is that big and diverse, and many people live in rural communities. They have royal flying doctors. I mean, it's just not easy to get to a hospital, much less an appointment for a doctor. So they do a lot of telehealth here, and I guess you have COVID to thank for that. But Western palliative care is turning into, they realize that if people are dying at home, which is where they want to die, it's so much more affordable. So let's use technology and let's use Zoom calls and let's use really Michael Franken's model that he used when he was in California, where all of these experts wearing these different hats are all on the Zoom call with the patient, and they are not siloed. They're working as a team with that one patient and that one family, and they don't have to go to the hospital. They're just realizing that's what's going to save money to an aging population here in Australia too. And I would love to see that model come to be, and it's going to have to really if people want to have quality care at the end of life and stay at home.
Whatever's effective for the person to be physically comfortable, and then everything else can come from there. I really stand on that. I don't really care about anything else, seriously. It might be the hospice nursing that I did for so long. I primarily worked with people with cancer
Mhm.
and are suffering with that illness, with the surgeries and all the mishaps that can happen with that. And so it's really important to me. I saw palliative care work. It works. It works. And so if you have the right team that knows what they're doing, because not all palliative care teams are equal,
Mhm.
right? Some aren't as good as others. If you have a good palliative care team, they will meet your needs at least physically, and then attempt to help with the relational and the family and your, emotional and all of that. So you have a fighting chance to have a peaceful end of life with a team that can help you, but only if that person is comfortable. If not, there's chaos.
Yeah. Do you mind spending just a minute telling us about El Gato?
Well, yeah, he had, I would say, probably the perfect end of life for how many years?
El
So
Gato is how you referred to your dad. So,
yeah, called him El Gato because he had way more than 9 lives. He almost died, I don't know how many times. So he was pretty popular on Facebook because he had lots of friends. He was on Facebook and our family and the whole thing. And so over the years, everybody felt like they knew him. It was so sweet. And he had such a powerful personality and laugh, and he had a beautiful smile. I'll give you a picture so you can have that here with this. But it was a very difficult journey. It was a very difficult, I had to step down from I was the chair of the NHPCO End of Life Dual Advisory Council, I think 2.5 years by that time. I had to step down because he just kept having all these exacerbations, even with me, even my sister, who's a nurse, anesthetist, and her husband, who's also a nurse, a community. He had a team of nurses, and with us, totally, we would call him. We were always saying how we were optimizing him, fluff and puff. We had so much fun discussing like how he was an optimal. My sister, being a nurse anesthetist, had him to the microgram. She caught so many med errors in every situation. We had so many hospitalizations because he had end stage heart, lung, and kidney. So he was pretty much a train wreck but he loved life. He had a great life. He was not in any pain. We just took care of everything. So he just bopped along, enjoyed his life. He was hospice appropriate for probably a good 2 or 3 years. And he never wanted to get on. We would say, "Are you ready for hospice? They'll help us with this and that." And he goes, "What do I want hospice for?" I said, "Well, because the doctor," goes, "I know, it's okay. I'm good with God. I'm good. You all are taking care of me. I'm good." And it wasn't like afraid of hospice, just hospice didn't make sense to him.
Well,
But he
he
had
had you,
us.
please.
Yeah, he had us. And my brother, who was part of the care team. And so, yeah, it was pretty extensive there, but it was wonderful. It taught me, it stretched me to a new place because caregiving is hard for anybody, especially when you're day in, day out for years. It's very, everybody who's done that journey knows what that's like. And it was no different for us. And of course, I'm very happy and grateful I got to do it. So, yeah, he died December 11th, 2023, and it's taken me about this long to feel like I'm ready to come back out to, so it just is what it is, y'all. Don't rush yourself, don't force yourself to get out
I
and
mean,
about.
you were so integrally a part of his passing. I mean, what were the takeaways for yourself and your own passing that you got out of that experience?
I'll tell you, he loved life and he took every inch of his decline. He just like, damn, the way he would reconcile the decline. I remember the last time he went to Brazil, he just loved going to Brazil every year. And I remember the year where there was no way he was going to be able to go.
Mm.
And I think he lived about 3 more years after that, and then all the other things he couldn't do. Then he was a musician. He played sax, he played bass, so when he couldn't play sax anymore, then when he couldn't really do bass anymore, then I got him keyboards. So then he couldn't do keyboards anymore. And then it was down to we would sit on the porch and listen to the birds. And he loved that. So
Yeah.
always, you know, and
Yeah.
I didn't get it at the time. I was just like feeling sorry for him. Like he couldn't play, keyboards. He couldn't do this. But no, he would just sit there and he goes, "Did you hear that?" I'm like, "Yeah, I did." Wow. And then he would just start talking. And then I realized that every time we went to the porch, which was throughout the day, he loved it. And I thought, okay, this is good. This is really good. He loves this. And then to add on top of that is he was a supervisor. We used to get irritated with him because he always wanted to micromanage when we were doing yard work. But I would tell my sister, I'd call her, I said, "Okay, I'm going to get him out of bed. I know what'll do it is I'm going to do some yard work." And sure enough, he goes, and starts shuffling outside to supervise.
Oh, that's
So
funny. That's funny.
yeah, it was good. I learned a lot about hospice, that some people, not just him, but he had a group of friends, and none of them would ever do hospice. That's not just something he would do. It wasn't until the very end that he did it. They just wouldn't. They had a breakfast they would go to, a lot of them daily. My dad would go about 4 times a week, but he was part of the core group and they were dying. My dad was 90 when he died. And they would sit there. It was hilarious, just saying different things at different times, but hey, in Spanish, "Bring me the bacon and eggs, I'm gonna probably have a heart attack in a minute. Just get them, I'm not eggs and the bacon before I drop." It is just so funny to listen to them and how they reconciled their life and their
Okay, so I need to like, I'm hearing that and I'm thinking I really need to like rethink that hospice is the end all and be all. If all of your dad's friends weren't interested in it, then what was going to their end of life look like? So now, and this is a question, are doctors in hospitals or facilities, who's caring for them at the end, and are they being able to extend any kind of palliative care? Are they knowledgeable in palliative care?
I didn't see anywhere he was. And everybody wanted him to live always and do the next treatment.
Right.
And always. And it was really sad. I'm not ready to talk about it yet in public, but it was really, really devastating. His last visit with his cardiac surgeon. We almost hate him now. He was so good with my dad all the way through. And the last visit, when my dad was so proud, he made his decision. This is what he wants to do. He wants to turn off the defibrillator. He really contemplated this. It wasn't a hasty decision. He really thoughtfully discussed it and thought about it and prayed about it. And he was very proud to go to the doctor with his decision. And the doctor spun on his heel and walked out. Thank God it wasn't me. My sister was there. She has more tact than me. If it would have been me, I would have pulled his coat back in the room. I would have. I'm not proud of that about me, but I am grateful it was my sister that was with him. And it hurt him, but he didn't wallow in it. He didn't, just said, wow, okay. So anyway, very disappointed in him there. But every doctor until the moment my dad chose to not pursue the next treatment was just always offering another treatment, even though they saw him going down. And the reason why he was going down smoothly was because we were micromanaging every step. Every medication. My sister was tight because my sister's a nurse anesthetist. She's in surgery all the time. She was micromanaging everything, titrating him perfectly. And so they always accepted whatever she recommended. She said, I would like to do this. I would like to try this. He seemed to not do well with that. Like lots of medications. I mean, when you have heart, lung, and kidney, and all the interactions. So he was a very lucky man. He was a very lucky man.
Well, okay, so most of us don't have a family of medical professionals, and the most of us, I mean, there's a whole bulk of people that live in rural areas, don't have the $80,000 a year that it's going to cost you the last year of your life. I mean, honestly, and because of the denial that so many people, no matter their socioeconomic background, denial is everywhere. What hope is there? I mean, do we just let people suffer?
What I'm seeing, I've been doing polls recently on people in the time period I've been asking, if you're in the time period, treatments have stopped working, that you're far from hospice, because in people's mind, they think hospice is way down there.
Yeah.
So I'm asking, if you're in this time period, hospice is far away, but treatments aren't working anymore. What do you need? What are you doing? Where are you spending your money for your support? What's going on? And I just did the last one this month. And it was startling to see not one person had the same response, the same issue, the same intensity about it. And when they said what they needed, it was not anything the same. And so what it really has me thinking, I've always known this and I've always taught this. If you're going to be doing end of life services of any kind, you need to do very specific service around a practical need, because that's all people are looking for. I don't care if you're dying, if you're in pre-hospice, if your treatments are working, it doesn't matter. People are looking for specific
Give me an
answers.
example.
For instance, one person was talking about going on and on. They had a very complicated situation going on, but the thing that disturbed her the most was the bed. All the issues they were having with the DME.
DME.
Durable medical equipment, the bed.
Yeah.
Of the hospital bed.
Okay.
And I'm like, I'm reading this going, you have this incredibly difficult situation here. But her focus was the bed and the other equipment that wasn't, things weren't working out. And that she felt like that was the biggest problem. She was going on and on about it. And I'm like, Okay, so do you know what I mean? How do you address that? If you're trying to say, I want to help you in this pre-hospice time period, but somebody is focused on that kind of thing,
Mhm.
then if you discuss, let's get your plans in order, that's not going to
Right.
connect.
Exactly.
So
Exactly.
so I like all the discussion around let's get your advanced directives done. I like let's make a plan. But when people are in need,
In it.
their need in the moment around what we call activities of daily living, around the doctor didn't do something right, and the person is suffering somehow, in they don't have money to go to the next referral. Like it's very different things,
Mm.
and it's all over the map. So the answer, what's the answer? It's a big problem because how are you going to capture the attention of people who are needing help, but they're not asking for the help you think they would be? Hey, I'm here. I'm an end of life doula, or I'm a serious illness doula, or I'm a person who can help you plan after treatment stop working. People don't see those words and think, "Oh, that's me. I'm going to call them and they're going to help me." They're not. So
They're
you
not going
have
to
to,
call. They're not going
they
to
that
call.
they're not, well, they're calling, they're talking to their friends, they're talking to each other on Facebook, they're finding groups, they're looking in groups. Their people are being resourceful.
Mm.
However, what we still read and see and hear are this tragic stories of people falling through the cracks. So just winging it and talking to people here and there as you find them in groups and on Facebook and reading an article here and there and talking to Chat GPT. Chat GPT is even wrong sometimes.
Mhm.
Very smart, but it's not always right. And so people are, they have more options to get general information, but to put it together for their specific situation, people are still floundering. So the doulas, to me, have the biggest chance to help make a difference here because resources within the system, within the healthcare system in the US, I don't know about Australia, you all have this great, report card. So maybe it's not true for you guys, but it is definitely true in the United States where we're getting more and more fragmented.
Mhm.
And the thing since COVID, the requirements for getting this and getting that service and coming back into here, this home health or whatever, people are in between. They're in all these places in between services.
Well, I mean, I go to Texas. I'll just use myself as an example. I go to Texas. I have a great doctor in Texas. I have Medicare Advantage. So, I mean, I had always had just Medicare with Medigap, but pretty much because of my age, I wasn't paying other than the insurance premium. I wasn't really paying for quality health care that I was getting. And I'll go into my doctor and they've done all these base things and cognitive and heart and all these things that are in my records. So when I go in every year and have my annual, compare it to that base level, and I'm really getting good quality care there. But I realize that I'm probably the exception and not the rule. And one of the first things that I am going to look at when I go back to Texas this time is because of all the changes at HHS and Medicare and Medicaid, am I going to be out a bunch of money that I think I'm not going to have to pay for? Now all of a sudden, am I going to have to pay for it? Are these premiums that I'm paying for going to triple in cost and things like that? So I'm somebody that can absorb a certain amount of that. I'm somebody that has the curiosity to look ahead down the road and position myself in a place that I'm going to be least impacted by that.
Right. Because you're
I
you're an
didn't-
end of life planner. Yeah.
I try to teach that to other people, but yeah, it's like if you're teaching 30 people and two people hear you, I feel like you're winning.
The thing is, though, nobody that I know they get excited about it, but they're not showing up
Are
for
you
the
talking about
information.
doulas or patients or?
So just normal people. When I see and when I have guest speakers say, and I invite my email community to come to this end of life event, end of life like advanced directives event, it will get a lot of registrations and then very few people show up.
Mm.
So I think it sounds like a good idea, but then something else is more important in the moment. What I noticed about my journey during the pre-hospice time is that throughout every day was different, and throughout the day was different all the way throughout the day. You just never knew what was going to happen. So if a sort of mini crisis happened at 10 in the morning, and if I was online, say for some instant, and then that issue came up, I probably would buy it, do it, call it, get it. But if 2 o'clock that situation took care of itself, and I saw that same those same ad or whatever, same person talking about, I would blow it off. I don't need it anymore. We already handled that. On to the next crisis.
Mhm.
People living with a person that they're caring for over time, over weeks, months, years, it's the crisis is in the moment, and then when it's gone, it's gone.
Right, right.
Living that way from crisis to crisis, taking a breath in between, trying to get a nap in. I don't see those people coming to advanced directives classes. I don't. That's not how they're going to get help. So, what I teach a lot to doulas is if we're out in the community, to me, this is where we are most impactful.
Yeah, I agree.
A community session, say once a month in the library or coffee shop or yoga studio or whatever it is,
Mhm.
and teaching about something practical that can help them or answering questions about this time period, something that will get them to know, okay, here is a person I can call if things go down. I know who to call now. That is everything
Yeah.
because now you'll be that person that they call when that crisis hits, and you can help them, and then they know who to call again. Then you're going to equip them, teach them, and then the next time that happens, they don't have to call you. Something else is going to happen. Because when somebody is going through the end of life, it can be all kinds of things, of course, that is going on. And
I'm
that's the way it is.
I'm just really glad that you highlighted that the importance of not only getting out in the community, but community. So wherever you're planted and you're hearing this, and if you are an end of life doula or wanting to be, I would say it's just almost critical that you get out there and have some death cafes or go to advanced planning workshops or network at, they have a dying to know day here. I mean, that kind of networking within the community. So the funeral directors and the other people know you're there. Don't
You're
hide
there.
your light under a barrel, you know?
Getting the others to know about you, that's good to do that. But if the people is who we want to help, the public.
Mm.
I've been teaching doulas for 15 years, and I really want to really start bringing this to families. And I'm looking for ways how to get the attention where it matters to them, where they can have accessible step by step guidance, because it's always different what's going on, and it's always different because the families are different, their access to care is different, their access to money, the disease process their person has is different, who's the caregiver is different. I can tell you one of the saddest things that I saw is my dad, like we discussed, fluffed and puffed, optimized, always clean, always looking good. We had to, he didn't like taking showers. We had to just, APS is going to call if we don't get you in there. But, we would go to doctor's appointments, and I would see and I'm just going to say little old men because that's my dad ended up, little old man. There would be little old men there by themselves, their shirt all half buttoned, there's medicine in a bag that was falling apart. Nobody was with them. So that just, whenever I would see that, their walker all half off the ball, just so heartbreaking. that is a reality, that there are so many elders without care. Their
Mm.
families don't live nearby. They're the only ones for whatever reason, you know, and it's real. The stories, the crying that you see, they show like people on Meals with Wheels going to deliver meals to some of these elders. They're by themselves. They're crying in so much emotional pain and loneliness, in poverty. Um, so all of this is real. And my feeling is um, end of life doulas are going to be the ones to mobilize people who think like end of life doulas. It might not be that title, end of life doulas. I don't care if people use that title or not, but I feel like the movement of end of life doula has brought into the consciousness of anyone who's heard it the role of advocate.
Yeah.
And
Yeah.
people who care about end of life and that time prior to hospice, people are dying long before they come to hospice. Those people, if we could have what I believe is, if those people are doing regular community education or conversation or discussions where people know where to come every Monday, first Monday or whatever it is, start to have neighborhood groups and watch your neighbors. You know, if you know a little old lady lives on that corner house and the yard hasn't been mowed in over a month, probably I wonder what's going on with that woman, right? So if we did, like in the United States, they have things called neighborhood watch for crime.
Mhm.
I would like to see it, doulas have that for elder care and
Giving me chills. That feels so right to me. They have something here called compassionate communities,
oh,
and they actually train, volunteers at a professional training level, but they're training volunteers to uh, go. I mean, so they're hooking up the lonely seniors, the people that need support. They have something here too called age care benefits, and it's stage level packages. And so there's going to be someone that's a social worker type that knows that this person on this block needs just someone to have a cup of tea with them. Come in and
that's
have
what
a cup of tea, and just, or maybe I'll mow your lawn for you. Oh, you need your windows clean? I'll clean your windows for you. Things like,
already showing. Yeah, they're already showing that. Like years ago, it was such a marvel. Oh my goodness, did you see this news clip on the neighborhood that is going and turning that woman? There was some big, everybody made such a big deal about it. This family moved into the neighborhood and they told the family, this is what we do with neighbor over here. And they were shocked. Like, are you kidding me? You're going to come approach us and tell us we're going to go turn somebody every night? Y'all are taking turns turning somebody. But anyway, that's what, and what you're describing, Claire, that's, it's a community. If you all are already doing it, no wonder you're number 4 in the world.
well, I have to say UK is number one, and UK they started the concept of compassionate communities. And so Australia has embraced that model. So if you Google compassionate communities, you'll get a lot of information about that. And I think it's something that, it would be so wonderful if,
Oh, we'll start about it. I'll
something
start.
that it's just going to be more important than ever because our healthcare in the United States is so unpredictable and all over the place.
I
And
think it's going to be doula-led, neighborhood-based, community, reaching out to the people in their community for sure. No question in my mind, that's the direction.
Mhm.
And I know doulas are scared. A lot of them, I'm not going to say aren't well trained. I'm going to say have had limited training, maybe a 2 or 3 month program, maybe learning a certain angle or two of a certain thing. That's not equipped enough. It takes, I train deeply.
and
And it,
you have to have years of experience after that training.
no, I don't believe in that. I believe that you have to have guidance and mentorship, like we do in hospice. We come into hospice as licensed professionals, not knowing anything about end of life.
Mhm.
And it's comical what us coming into end of life. We're not, we're not very good at end of life when we come in not knowing how to deal. It's a whole different way of helping people, talking about the illness, talking and being with people. To me, if you have a strong grounding in that and in yourself and where you have your gifts and in your resourcefulness and hang your hat on that, then on your expertise and build your little service based on what you know inside and out, there's your confidence. Then you can come out as a companion without the pressure of having to be some important guide that knows
Oh,
everything.
yeah. Oh, yeah.
Side the people and help them. And there's no pressure in that. And I feel that so many doulas, it takes time to get seasoned inside of you enough to step out professionally. I've seen it myself with my own doulas. They're very talented. They've been trained very well. I know what I'm doing, and it still takes them time. And not everybody gets that kind of training. They just will have a 2 or 3 months, sometimes 4 months training, and no wonder they're scared. So to me, I think that if you could find a good hospice nurse in your town, here's another thing you can do. If you can find a good hospice nurse in your town and ask them, will you mentor me? Can I call you? Can we have some kind of relationship where I share with you my cases? Pay them, offer to pay. Don't expect anybody to do something for you for free. And not hold the hospice nurse accountable for anything you do wrong either. I have always encouraged this kind of connection as well. I can only train so many people. There are many people, you don't need a certification, but you do need to know what you're doing. You do need to be accountable to somebody. You do need to have community. You need to have people ahead of you. This is too serious to go out there winging it because you've taken a 2 or 3 month certification program. That's not enough. No wonder people are staying home. They're
Well,
scared.
when I said experience, I was just like, I was in that same place after I was certified in your program. And it was just people that came to me that I started work with, that I could start applying what I had learned for me to build my confidence to go, and then being a hospice volunteer has been huge too, because I got an extra level of training for another specific role. It's not the same as the end of life doula, but another specific role. And it was just like you gave me a tool bag that it was like, and every time I used one of those tools, that tool was just like, yep, this is what I need. Yep, this is where they are. Yep, this is what we do. And I have so much confidence about that. I really do. But somebody had to teach me what are the tools in that tool bag and how to identify where people are. And I think that's the most important thing is being able to go into a situation, a family, a patient, assess where they are and being able to go, okay, this is where we are. This is what we need to focus on now. Like you said, it may be working on the bed, so they have a proper bed. It could be something as simple as that, but it's a non-medical thing that we can make such a difference. Such a
Oh,
difference.
the non-medical doulas are doing fantastic consulting, fantastic resource gathering, companioning, setting up plans, setting up ceremonies. The sky's the limit on what doulas are able to do based on their own skill set. I think though the main thing is whatever you do, whatever you want to do, I feel like just swallow it, get out in the community and just start holding conversations at the very least, and you'll be surprised how a lot of the fear can shake off. See if you can find a hospice nurse that will talk to you if you don't have a group of people. The thing about Facebook groups sometimes is that you can't be yourself in there. People are posturing, of course. They don't want to look like they don't know something. There's just in free Facebook groups, it's not the best place to grow and scale your business and to talk about client issues. It's just not the place. People don't feel comfortable doing that there, and I understand, and I don't agree with
I
doing
think
anything.
early on, like I was in a group with Katie Butler, and I was just like really learning a lot from the people that were in the group. And so I was gaining at that stage where I was gaining a lot of really good information when people were talking more clinically about things that normally they wouldn't be talking to you because you're a doula about clinical things. But that was helpful for me.
Yeah, yeah. You'll find groups like that, definitely, through different parts of your phases. But if you're going to be serving, I feel like you need to be in a group that's serving, and
Mm,
there's people ahead of you that can help you with that,
yeah.
because issues can be, quite complicated.
So, Deanne,
Um,
I'm not gonna, I mean, I know you've got it's late for you, it's early for me, and I'm going. But I mean, I love the idea about you getting, a neighborhood watch thing together. That sounds so good. But what's the future of how you see your business going and the role of end of life doula going and just overall end of life care? How do you, if you could paint the perfect picture, what would that be?
well, for me, I'm in my 60s now, and I've been very grateful and honored to have been carrying the torch for these last 20 years. And the development we've had so far, and really the last 10, really 15 since I started the program. I really want to pass the torch, and I want to be here for other trailblazers, and I want to help you, whoever's out here, get that thing figured out. I talk to people all over the world. They're building bridges where there's nothing, building pathways where there's nothing. That's what I did when I started. There
Mm,
was nothing. And you have an idea, you have a heart for it, you have a passion, you have energy, and you want to create something new. What I want to do now for me and my business is I want to be there for families. So I am exploring. I have one of the doulas. She's a PhD, a palliative nurse practitioner, professor. She's starting her own podcast. She already has a platform of thousands. Um, I would. I'm not going to start a podcast, Claire. I know you work very hard on, but I will support her and do everything I can for her to have that
yeah,
podcast, right? For me, I would love it if I could figure out how to help families. Most families in their myriad of need, they're never looking for the same thing. They're not thinking end of life, right? End of life is far away. So we have to get ingenious about how do we become um, on their mind, should they ever need support, they can have it,
yeah,
because that's the only way they're going to stop flailing in the system. Not everybody's reading the books that the doctors are writing. It's just a matter of awareness. That's why I think if people have these monthly meetings and sessions, I really support that. Then the groundswell is gonna happen, because people will be intrigued, because they are being affected by life, and they are being affected by the dying of someone they love. And it's at different times, different people, and that the community is just going to grow and grow and grow. I feel like that's the only way. So that's what I would love to support other people doing the next round of work. I mean,
one of the
it's
things that I really want to do a shout out and mention here, because I'm going to let people, you say how people can get in touch with you. But if you're anywhere on the planet and you need like immediately good end of life support, get Deanna's book. So the title of it, it's Accompanying the Dying, Practical Heart-Centered Wisdom for End of Life Doulas and Healthcare Advocates. Get that book because honestly, you just don't have to go into a chaotic, fearful situation without some very basic, practical, um, incredibly thought out. Get your own tool bag to get ready. If you can't find an end of life doula, get your own tool bag and get her.
that book I for that reason, so that families could have something in their hands. I wrote it for for doulas and healthcare advocates. I have that in the title because I knew they were the ones that would pick it up first, and that they're the ones working with more people. And now, but also I'm getting I've been written by many families who have gotten it and thanked me for it and all of that. And this screensaver here is from the book. This is the cover of the book, and it is from Maui, from my friend and colleague, Reverend Bodhi B. from Doorway into Light.
I've interviewed him.
He's amazing. But thank you, Claire, for having me. And I feel like anybody who has this in their heart, you can do it. You just need support and guidance, and you need, just don't feel bad that you need that. We need, you know what I mean? People go, I should know this. No, you shouldn't.
We need each other for sure. And I can't thank you enough for all your generosity through the years, Deanna. You have just always been so generous with mentoring me and so many others. And I just can't thank you enough and say how much I love you for that.
Thank you, Claire. I love your work. Thank you.
And for the listeners, there will be a link to her school and her book on the podcast notes. And I'll let you go to bed now. Thank you, Deanna. I love you. Thank you for joining us on Dying Your Way. If it's inspired you, then please spread the word. Leave a rating and review so others can find out about us. To learn more, connect with us on Facebook or our website at dyingyourway.com. A special thank you for the artist Mel Dobra for letting us use her song, Smoke and Flame, as the soundtrack of our show. I invite you to return, hear each episode, and be part of the conversation on death literacy. I am Claire O'Berry, and this is Dying Your Way.
Reaching